Hello, and welcome to another installment of Business School Alliance for Health Management's virtual series, Lessons Learned in the Healthcare Marketplace during the COVID-19 era. This webinar explores the greatest supply chain challenges ever, COVID-19 vaccine. Next slide. My name is Mitchell Burning, and I'm a University of Colorado Denver Master's of Business Administration, Health Administration candidate and treasurer of our school's Health Administration Student Organization. Today's webinar is presented by the Health Administration Student Organization at the University of Colorado Business School. The Health Administration Student Organization is responsible for organizing student events, educational seminars, webinars, and serves as the student representatives for UC Denver's nationally ranked Masters of Business Administration and Health Administration program. On behalf of the entire Health Administration Student Organization, we would like to share our deep thanks to the Business School Alliance for Health Management and our program director, Rulon Stacy, for fostering this opportunity for today's webinar. Next slide. The University of Colorado is proud to co-host this event with the Business School Alliance for Health Management. I would like to invite Dr. Stacy to speak on behalf of BAHM and say a few words.
Thanks very much, Mitch. Mitch is correct. This is another in a series of events by the Business School Alliance for Health Management. University of Colorado Denver has been fortunate enough to be allowed to present this version and have our students become engaged in this, the student leadership. BAHM is an international consortium of 20 premier MBA programs that are dedicated to the business focus of health management. I happen to serve on the board of BAHM, and I'm engaged with that group as we work diligently to further the research and education and academic prowess of the schools who are involved. I would invite everybody to look on the BAHM website for others in other parts of this virtual series and to find out more about the premier academic resources that are available in the schools of the Business School Alliance, the universities that are in the Business School Alliance for Health Management. Oh, and there we go. I knew we had that. Thanks, Lindsay. That's them. Thanks, Mitch. Oh, there's even more facts and figures. Thank you.
Thank you, Dr. Stace. Now it is my honor to introduce today's esteemed panelist. First, Dr. Julia L. Swann is the department head of the Fitz Department of Industrial Systems Engineering at North Carolina State University. Dr. Swann has conducted research, outreach, and education to improve the way that health and humanitarian systems operate domestically, in the US, and internationally. She's been conducting analysis of the epidemiology and public health impacts of the disease spread of the pandemic, including influenza 2007 to today, and the COVID-19 epidemic 2020 to today, with colleagues from Georgia Tech and North Carolina State. In 2009 to 2010, she was on loan to the CDC as Senior Science Advisor for the H1N1 pandemic response. Currently, she is leading a team selected by the CDC and the Council of State and Territorial Epidemiologists to develop and forecast and decision models to support the state decision-making during the COVID-19 pandemic in the US. We also have with us today Dr. Mario Macis, an affiliate faculty at the Johns Hopkins University, Berman Institute of Bioethics, associate faculty at the Armstrong Institute for Patient Safety, Quality at JUH Medicine, and a faculty research fellow at the National Bureau of Economic Research and the Institute of Labor Economics. Between 2016 and 2019, he served as the academic program director of JHU Carey Business School, MS in Healthcare Management. Dr. Macis is an applied economist, and his work focuses on how economic incentives interact with psychological factors and social norms to drive individual behavior and policy relevant outcomes. His research interests include pro-social behavior, morally controversial transactions, global health, experimental economics, development economics, and labor economics. Dr. Macis has been a consultant for the World Bank, the International Labor Organization, the National Marrow Donor Program, and the United Nations Development Program. Our own Dr. Jeffrey Helton holds an adjunct faculty appointment as the Healthcare Finance at George Washington University and Texas Tech University Sciences Center. Much of his career has been spent as Chief Financial Officer for several healthcare systems across the United States, where he's led financial turnarounds of organizations previously in bankruptcy or receivership. Dr. Helton earned his doctorate of philosophy and healthcare management from the University of Texas, a Master of Science in Hospital and Health Administration from the University of Alabama, Birmingham, and a Bachelor of Science in the Business Administration from Eastern Kentucky University. He is co-author of Healthcare Operations Management, a systems perspective, now in its third edition. Dr. Helton currently teaches health selection of applied economics for managers and healthcare operations management at the campus at University of Colorado Denver Health Administration Program. He's also currently one of my professors. Next slide, please. This is today's agenda. It's fairly straightforward. First, the three panelists will speak for 10 minutes each on their areas of supply chain research. This will be followed by a robust question and answer period. Now, let's begin with Dr. Julie Swann speaking on understanding supply chain challenges of the COVID-19 vaccination.
Thank you so much, Mitch. Can you confirm that you can hear me?
We can, thank you.
Great. So I'm delighted to be with you here today. And as Mitch told you, I'm an industrial engineer. And so we're going to talk about how that fits into this grand space of COVID-19. And I have been working on pandemic modeling since 2007, which that predates a little bit our last pandemic, H1N1. And we were doing this because we wanted to really pivot towards the public health systems, both health and humanitarian, and do what we could to bring some of our engineering techniques and tools to that space. And we had gone to the CDC and Red Cross and other organizations and asked, what are your biggest challenges? And planning ahead for that next pandemic was one of the ones that arose from that discussion. And so that eventually led to my being on loan to the CDC, where I was really looking at the distribution of vaccine and other medical countermeasures. So, and I looked both at that during the fall of 2009 and afterwards as well in an evaluation period. If you can go to the next slide, please. Now, many of you may know a lot about the public health system, but it really is a very complex system where all of these entities do not necessarily work together. So you've got lots of federal agencies, including HHS and CDC, which is also under HHS. You've got the Food and Drug Administration. Now you've got the Emergency Management Organization, National Institutes of Health. You have many other government agencies as well, state and local government agencies. You've even got things like educational systems and other ones like that. And you've got companies, providers and pharmaceutical companies and several different kinds of companies. And you've got, as I mentioned, these state and local healthcare providers. Now, generally, as an industrial engineer, I take a look at a system and I ask questions like, what can I do to help make decisions more efficient, which may mean that they are lower cost or faster speed, more effective, getting the right product to the right person at the right time, and or possibly more equitable. And so to do that, you have to start with what are the decisions and what do they look like? And then secondly, I'm really looking at the mathematical and computational tools to bring to bear on the problem, and then others do other kinds of things like qualitative research and other things. And the third component of that is communicating results and working with decision makers to disseminate. Now, let me talk a little bit about the distribution system for vaccines and specifically for the vaccine in a pandemic. And much of this is drawn from the experience from H1N1, but a lot of it will be used in the same kind of structure for COVID-19 as well. So the producers are working on making the vaccine, and US government has been investing with them so that they can afford to go ahead and make some initial products, and even, without too much financial risk. These will be approved, and except for the Pfizer vaccine, the others are all sent to the McKesson Distribution Center. And from there, the CDC would make an allocation to the states to say, this is how much vaccine you have available to you, and this is the type. Within the states are working with those providers within their state and with the local health departments. So it might be hospitals or pharmacies or employers or all different kinds of organizations. And they're determining how much they're going to send to each one of these. The shipping is done from McKesson directly to those providers. Individuals come and become vaccinated. They get a shot in the arm, if that's the delivery mechanism. And then this is all monitored afterwards. So you've got all kinds of different technology systems that are coordinating the ordering and distribution. You've got systems that are tracking vaccine over time, and you've got ones that are putting in reminders, because we know that for several of the vaccines, there will need to be 2 doses 30 days apart. And there are lots of different questions in this system. Who's going to get the vaccine first? There are a couple of drafts out there laying out some priorities, but they're not finalized. Where are you going to get the vaccine? How safe is it? How effective is it? Is it safe or effective for different groups at different rates? What are the right technology systems to make this whole thing more efficient? One thing that we saw in H1N1 is that most states didn't have the capability of seeing where inventory was in their system and really using that to allocate vaccine as additional rounds of it became available. So those are some of the different things that I've looked at. Now, one of the vaccines in particular, that's one of the forerunners in the phase 3 trials, is the one from Pfizer. And Pfizer is special because that vaccine needs to be stored at -70 degrees Celsius. And that's really cold for a vaccine. So that's colder than most other vaccines that we have. And these specialized freezers, sometimes referred to as a sub-80 freezer, are not available at all locations. Most doctors' offices would not have them. You might have them at some large hospitals. Typically, even commercial pharmacy like a CVS would not have one in-house, although they would potentially have one in their distribution center. And so Pfizer has developed a specialized box, and so they're going to ship their vaccine in a specialized box. But instead of being in units of 100 like the other vaccines that we have information about, there'll be 975 doses in this box. You can open it up for 1 minute, up to twice a day. And it can stay in this for 10 days. And if you take it out, the vaccine has about 4 or 5 days when it would still remain good. So just think about how you would distribute that vaccine, not just distribute it en masse, but distribute it to subpopulations, just medical workers working on the front lines of COVID-19, just populations above 65 with 2 or more health conditions that put them at greater risk. There's some huge challenges there that states are struggling with, and local health departments and their providers as well. So that's what we're facing right now, and we're all working through it. Of course, the states have some plans, and they're continuing to refine those. But this vaccine, which is a new kind of technology, and it just has new kinds of requirement, and that infrastructure is not available everywhere. So that's one of the areas at which I've been looking. Lindsay, can you go to the next slide, please? If Lindsay can go to the next slide, I'll tell you a little bit about some of the modeling work. Oh, I see it on your side. Thank you very much. That we've been doing. So we have lots of different models that we built for influenza, for COVID, and other things. We are using agent-based models over a network. So we're pulling in information at the census tract level on individuals who are interacting with each other in households, in workplaces, and schools, or in the community. And then we look at the disease spread across that state, or within census tracts, or within subpopulations. So some examples of some of the things we've tackled in the past include looking at seasonality associated with influenza, mutations associated with influenza, the role of mass gatherings and travel on influenza spread. One really important finding there is that if a bunch of people travel, let's say for the holidays, like Thanksgiving or Christmas, and they go from where they live and they mix with some other people, and then they come back to where they live, then that increases infections by approximately 1%. And that's 1% may sound small, but when you add that up for each state and for each country, we're really looking at some substantial potential increase in infections and deaths. So if you're thinking about traveling, really think very carefully about that and what you're doing and those kinds of things. There are particular interventions, and we're putting these into our models. So masks or face coverings are a great example of this. And we find that if 60% of the population were to wear masks that are 50% effective, then this would greatly reduce infections and deaths. Deaths would reduce by about 25% from that. And if you can increase the quality of the masks or the compliance with that, then it gets even better. And all kinds of other things. So we're looking at scenarios with different amounts of vaccine rolling out, different kinds of priorities, those kinds of things. Now, one of the things in that mask picture is the second one, going from that tall peak down to the one that's more like the green or purple down at the bottom. We're also doing a lot of thinking about vaccinations right now, and there's a trade-off between taking those who are at risk of exposure versus those who are at risk of dying, and then even thinking about using vaccine to stop transmission. So there are lots of things in that space as well. Now I see that I'm probably up on time. So the last thing that I will say on this is that inequities are really important in the COVID-19 pandemic. We've already seen much greater impact on communities of color, and you also see differences urban, suburban, rural. And so, you know, when we can, making sure that we're aware of that through data and then are taking that into account in our interventions is really important. Lindsay, you can go to the next slide if you don't mind. And with that, I think I will stop my time.
Thank you so much, Dr. Swann. That was scary but informative. Next, we will move on to Dr. Macis. Thank you.
Hi, and thank you for having me here. It's really it's a great pleasure to be part of this panel and this conversation. I'm Mario Macis. I'm a professor of economics at the Carey Business School here at Johns Hopkins. I'm also affiliated with the Hopkins Business of Health initiative. In the next slide, if you could move forward to the next slide. So this is really, as the title of our event indicates, it's really a formidable challenge, the COVID-19 vaccine. So there are at least, the way I see it, at least 4 critical steps. The first step is the development of a vaccine, of at least one vaccine that you know, works reasonably well, sufficiently well, and on that front we are doing quite well. There are 10, 11 vaccines that have reached phase 3 clinical trial. You know, we might have an approved vaccine as early as late 2020, later this year, or early 2021. So this is really an amazing scientific achievement. And we, as you know, as humans, we should be very proud of this. And of course, you know, but that's the first step, and it's a major step that we've been able to condense in a short period of time. But it's only the first step, right? But then there's a second step. We've heard about it, you know, we need to manufacture enough doses. The third step, we need to, you know, take care of storage and logistics and distribution, making sure that those initial doses reach the prioritized populations, and then that enough doses reach, you know, every individual who wants to be vaccinated. But then there's a fourth step, and you know, as a social scientist, as an economist who studies human behavior, that's the step that I want to focus on. Is, you know, we will need to make sure once, you know, steps 1, 2, and 3 have been completed, it's not over yet, because we're gonna need to ensure that enough people take the vaccine, and this might actually prove to be a challenge, an additional challenge. On this slide, I'm showing results from a recent Pew Research Center survey There are other surveys that show similar results. Turns out that only 21% of Americans currently would definitely want to be vaccinated, and 30% would probably be vaccinated, accept to be vaccinated, which means that 51% would probably or definitely be vaccinated. 24% though would definitely not get vaccinated, and a total of 49% do not intend to be vaccinated, are more likely not to be vaccinated than otherwise. And the numbers have been worsening over time, as you can see in the chart. The issue appears to be politicized. A larger proportion of Republicans do not intend to be vaccinated, but there are plenty of skeptics in both camps, and this is concerning. Why is this concerning? Well, the idea is that vaccination can protect us if we achieve herd immunity, and most experts agree that for that to happen, at least 60% of the population must develop antibodies. Now, if with these numbers, right, if only 50% of the population actually gets vaccinated, we will not achieve a sufficient herd immunity, even if the vaccine ends up being 100% effective, which is not likely. Dr. Fauci and other experts mentioned that we are aiming for a 75% effective vaccine, but the FDA said that a vaccine will be approved even if it's 50% effective. So the effectiveness will be less than 100%. If the effectiveness is say 75%, then to achieve 60% immunity, we need 80% of Americans to get vaccinated. And given the results from this survey, it's not obvious that it will take some effort. It's a challenge. It's part of the challenge that we are talking about. So the next slide, I made a list of reasons why people are reluctant to be vaccinated. The main reasons that come up in this survey and other surveys is concerns about safety, concerns about effectiveness. This is a sort of big number. About 80% of Americans, both Republican and Democrats, so regardless of political leaning, they believe that the process of vaccine development is moving too fast. Only 20% worries that it's moving too slowly, and they're concerned that a vaccine might be approved without having fully established. This is not necessarily true, right? This is the perception. Okay, people have this perception that a vaccine might be approved without having established fully its safety and effectiveness. So speed is important, but trust in the process is at least just as important as speed. Plus, some people might want to wait until others have taken it just to see, again, if it's safe and sufficiently effective. Additional consideration, they might prefer to wait until a second or third vaccine are approved, which might be better than the first vaccine to be approved. So these are sort of additional reasons why people might be reluctant to take the first vaccine that becomes available. Then there's an issue of, some people, it's actually more than 50%, they believe that they don't need a vaccine. So there's a misperception about an underestimation of the risk. And it could be that this is because most people don't know anyone personally who had sort of severe consequences from COVID-19 or who died. For a substantial share of Americans, cost is also a concern. Cost, interestingly, is also a concern among individuals who are inclined to take the vaccine. They say, look, if I have to pay out of pocket, I might actually, reconsider. And so also, same thing, if the vaccine turns out to be less effective than they believe, that would also reduce for some people the propensity to actually get vaccinated. So all this, to me, indicates that misperceptions or concerns, so these are important factors. And this means that public authorities need to manage expectations and information extremely carefully. People need to people rely on sources of information that they find trustworthy. It is a danger that if certain agencies become politicized, if individuals perceive that political reasons or other reasons other than science are driving communication. So we have to be careful about that, and our politicians need to be careful about how they communicate. So there are other sort of pieces of information that we could gather from surveys. Like, for example, some people are likely to trust figures like scientific figures like Dr. Fauci. Other people are more likely to trust local authorities, such as their priest or minister, or their primary healthcare physician. So we need to find out which types of messengers are more trusted by different types of people. So not everybody trusts the same sources. So we need to find out which is the best vehicle, the best messenger for different groups of people. Some people trust their friends. In some circles, getting vaccinated might become the norm, and so making it clear that getting vaccinated is the norm might be part of the of how we get more people to get vaccinated. So look, these attitudes might change over time. So when we have a vaccine and when the first priority groups receive it, for example, first responders, medical personnel, healthcare workers, when they get vaccinated, then perhaps the people's perceptions might change once they see that the heroes of this pandemic are willing to be vaccinated. The perceptions about safety and effectiveness might change. So we shouldn't just think that these attitudes are immutable. We should continue taking surveys and looking at surveys as time passes. Explaining the science in simple terms would be important. And managing expectations, like explaining, look, what does it mean for a vaccine to be 60% or 75% effective? Does 75% effectiveness mean that does that mean that 3 out of 4 individuals achieve full immunity, or rather that a certain fraction of those develops full immunity, whereas others get very sort of minor symptoms from COVID? So explaining the science in simple terms would help. The cost issue can be overcome by providing a vaccine for free, or heavily subsidizing it. We shouldn't discount those cost concerns. We will also need to make it very convenient, minimizing frictions and obstacles. Employers, in this respect, employers can probably help a lot, because companies have a strong interest in resuming normal activities and making sure that their workforce gets vaccinated. So resorting to strategies, and I'm almost at the conclusion of my thoughts. Resorting to strategies that worked before. Of course, we never had a new vaccine for an infectious disease such as COVID-19. But we do have some experience from inducing people to get vaccinated for the flu. I'm talking about adults in particular. So, for example, encouraging people to make concrete plans, to commit to to scheduling an appointment. That has been has worked in the past to contribute to induce people to get vaccinated for the flu, or making it easy, making vaccination the default option. Of course, people can always opt out from getting vaccinated, but changing the default into you're gonna get vaccinated unless you opt out. That has also helped in the past. Sending reminders also helped. Removing barriers to that can help with reducing procrastination, but also providing financial incentives. There has been Robert Litton, an economist at the Brookings Institution, has recently suggested, and the proposal has been endorsed by other economists, that providing financial incentives could also be one more tool to help with this, challenge of getting enough people vaccinated. I guess I'm gonna stop here. The behavioral aspects of surrounding assuming that hopefully when we have a vaccine, the behavioral aspects, barriers to ensuring that enough people actually get inoculated, get vaccinated, should be taken into account, and we should just now start formulating strategies to try and overcome those barriers. Thanks.
Thank you, sir. So before I jump to Dr. Helton and his research, I'd like to remind the audience that this is about to turn into an interactive exercise. So you are able to post Q&A questions to ask what you think or what you would like to know from the experts. So with that said, Professor Helton, or Dr. Helton, excuse me, I'll turn it over to you.
I answered to a lot of names. All right. This has been fascinating just to see some of the big picture concerns from my predecessors in this panel. Hopefully I can kind of plug in some of the ideas that they've raised here as we talk about making it that last 50 feet from the arrival of those inoculations to the actual inoculation event itself. Lindsay, next slide. Now, a lot of what I'm going to talk about here is really going to go into three different buckets: population, place, and process. I always try to make those sort of easy to remember acronyms. But one of the things that those of us in the field should be thinking about is we probably already have the framework for a good plan. Our mass casualty event plans, if we have, if we're in a hospital or a large clinic situation. And we still have some lead time. Now, based on the comments you've already heard this morning, there's a lot to consider here. And I'm going to pose some questions to you to think about that really integrate some of the ideas Dr. Swann has raised about the logistics of the production of these immunizations, Dr. Macis about some of the behavioral aspects working within our communities. There really is a significant interaction when we talk about population, talk a little bit about the place and the processes for actually making this happen. Next slide. All right, so let's talk about the population. Now, one of the things that will be a little bit of a unique operations management challenge here is that the volume of patients that we're going to serve really is going to be determined by the availability of immunizations. And what you see in the illustration here is kind of a projection of a growth in availability of doses. And so from an operations perspective, we're going to have to plan for 3 different tiers of demand. And that demand is going to be driven by the availability of vaccines. And the other challenging issue is going to be not only predicting how we go through this wave, if you will, but how many doses will be available within each local jurisdiction as we go through those waves. Will that wave be a high wave or a low wave, so to speak? Right. And so we really need to be thinking proactively about how we're going to attack this problem. Next slide. And so some suggestions for dealing with just this population element is use some of the ideas shared by the other panelists here, and maybe think about doing some modeling. Do a little bit of scenario analysis to look at your community, the people you think you're going to serve, and start thinking about the low, medium, high sort of scenario that you may run into, one, depending on the availability of vaccines and where you are in amongst those 3 production phases. You're also then going to have to vary your plans. And Dr. Swann, your comments about the handling of immunizations really influences a lot of what I will say here, because we don't know what the logistics are going to be for handling those actual inoculation vials. And so we've got to not only think about variations in demand, but then the logistics behind that. And I'll talk more about that in process. Those of you that have the ability to do some simulation work might want to think about how you would simulate different iterations of availability of doses within those 3 waves, if you will. All right, next slide, please. Let's talk about the place. Well, obviously, it's going to depend on where you're at and the type of organization that's going to be operating that immunization site. Now, it might be easy to think, yeah, we're just going to step outside and do this in the parking lot. That'll work as long as we're not in Sioux Falls in a snowstorm. All right, and so we do have to consider inside operations for many parts of the country as we start to go into winter. Now, some of the things that you'll need to consider, and again, you can lean back on the population estimates that I just described to help guide some of those decisions. All right, you certainly want to have the capacity that allows for an efficient throughput with adequate social distancing. I keep having these sort of, I want to say nightmare, but I'm not sure if that's the right word, where we could have a situation where our immunization sites become a super spreader event. And so we certainly want to have the opportunity to do what we're doing already, to protect the people, especially given that we're not exactly sure yet of the efficacy of the inoculation that's going to come into the field. And so we do have to be cautious about how we handle our patients. Ideally, we're looking at sites that have a one-way traffic flow. We get them in, we get them out, and we don't have interactions between different components of that traffic flow. One of the other things that will be really important from a clinical perspective is we have to build into that traffic flow at least a minimal amount of time to observe the patient right after the inoculation for any immediate reactions. Now, that's certainly going to be a constraint on our throughput modeling. It's also going to be a little bit of a bottleneck that we're going to have to work through. And we're going to need resources to make sure that we're timely moving people into that queue, waiting appropriate amounts of time with appropriate observation, and then clearing that queue. All right. So we're going to have to make sure that that traffic queue is sufficient to hold traffic for a long enough period of time to have a safety observation before we discharge the patient from our immunization site. All right, and so we're going to have to also make sure that we're considering infrastructure. Dr. Swann's points I really take to heart there, to maintain that cold chain for the immunization doses. And yes, security. Some of the plans that I've talked about were actually informed by my experiences standing up 2 field hospitals after hurricane events, Hurricane Andrew in 1992, and then Hurricane Ike in Houston in 2008. And security is an issue. Because these doses could become a black market commodity falling into the wrong hands. I saw that a lot with just dealing with simple narcotics in other field hospital situations. Considering where we may be at, security could be an issue, not only for the medications or for the immunizations, but also just to manage the crowds. All right, again, modeling is a good idea here, and try to find other potential bottlenecks other than the one that I've identified with the post-inoculation observations. Next slide. All right, so process, all right, you've got to try and maintain throughput and try to identify those steps that created a bottleneck and minimize the bottleneck wherever you can. Now, because we don't know exactly what type we're going to be handling, the type of inoculation yet, we have to think of 3 different sort of supply chains at site. All right, will it be refrigerated, frozen, or that ultra code, all called the sub 80 that Dr. Swann mentions? All right, and certainly we're going to have differing processes based on that product, and especially with those frozen or ultra cold types of inoculations, we're going to have to designate resources to monitor cold chain. We got to make sure that if that cold chain is broken for those doses, that we're handling them appropriately and we're not inadvertently dispensing medications that or inoculations that have been compromised. Right, so we definitely have another constraint that goes into that last 50-foot model. Certainly managing inventory is a tough challenge anyway. Here's another complication, especially if you're using automated inventory management. The doses, according to the information I've received from CDC, will be shipped without an expiration date because we don't know what the shelf life of this product is. We can assume it to be fairly short, but we don't know for sure. Right. And so, again, that's where you're going to have to designate resources to managing or monitoring that inventory. And certainly, you're going to need a backup of other materials just to give the doses. PPE for sure. The diluents, adjuvants are the mixtures that you'll use to dispense the medications. Now, the CDC is expecting to ship a nominal amount of those products with the inoculations. That includes syringes and needles as well. But you've also got to maintain your routine care and make sure that you have enough of everything to go around. Sharps containers are another thing that come to mind, all right, because they're not going to be shipped. We need to start thinking ahead about how we're going to manage dealing with the Sharps safety. And again, because we're giving routine care at the same time. Next slide. All right, staffing is going to be a big issue, especially in underserved communities, because you're also going to have to take care of routine emergent care. Who's going to give the shot? All right, and then documentation could be a challenge, especially if we're using that 2-dose regimen. And then reporting of the dose to be able to track the initial start. Now, certainly we've got mechanisms out there. Epic, for example, has messaging already built into its system that will communicate with immunization databases. So we're going to be able to do routine reporting, but you may want to check to make sure if you're not on an Epic platform, that your EHR platform will be able to do that communication. Otherwise, you've got another process constraint you have to address. Certainly tracking reactions will be an issue because you're going to need to identify those reactions and report them. You're also going to need resources to pay for this. So this is, again, an advanced planning challenge for those people out on the front lines. Next slide. As I've mentioned earlier, service volume is going to be a challenge. All right, so plan ahead. All right, make sure you're able to understand what's going to happen in terms of that wave of available doses. Make sure that you're thinking about logistics and moving people through quickly and safely while you have safe holding areas to observe for reactions and maintaining that cold chain, as well as securing your site and the materials. Refer back to your mass casualty plans. Be sure that you're able to adapt them as need be based on some of the constraints that I've identified for you. Really kind of think assembly line, because for the most part, what we're talking about is building an assembly line. Next slide. So as I wrap up, think about processes and traffic flows. Map them out now. Don't wait until you get the word that the inoculations are coming. All right, make sure that you're building reserves now of those materials you're going to need, because what comes with the inoculations will be a minimal support supply. Errors are going to happen. Prepare for them. Also, make sure that you have considered what's going to happen with your reporting processes so that it can be as seamless as possible. So that's all I have to offer. Mitch, I'll turn it over back to you.
Thank you very much, Dr. Helton. It was very informative. We have a few Q&A questions coming in, but as monitor, I'm going to take my liberty and ask my question first. My biggest question right now is actually to you, Dr. Swann, on uptake rates for the differences between like a CVS and like a hospital scenario. Is there a significant difference in the research you've done on those uptake rates between those two types of locations?
Thanks for that question, Mitch. Let me back up a little bit and say that you might be sending vaccine to different locations to reach different populations. So if you want to reach medical workers who are on that front line of caring for COVID patients, that's an example where it might make sense to send vaccine to a hospital. Or if you're in a phase where you're sending to working adults, then it might make sense to send to a very large employer who has the capacity to vaccinate on site where people are. But you mentioned commercial pharmacies, and that does get at some of the things that we found from the H1N1 pandemic, We studied the distribution systems of each one of the states and then looked at the factors to see if we could relate them to higher immunization uptake rates in those states for 3 different populations: adults, high-risk children, or adults who are high risk. And what we found is that when states sent more of the vaccine to locations that we think of as being more open and having more access, then that was associated with higher immunization uptake. And so, as an example, a commercial pharmacy might be open after 5 p.m. It might be open on Saturdays. And if you compare it to another kind of setting, let's say a cardiologist, that's not normally where you get your vaccine, and you may not go there, but maybe once or twice a year. It may be a little bit further away from your house. These are just examples of why sending to these locations like commercial pharmacies, like community clinics, can be a good strategy to try to reach people close to where they are at hours when it is convenient for them.
Thank you. And building off that, Dr. Helton, what are the business concerns that commercial locations like a CVS or a Walgreens would have distributing a vaccine at this level?
I think there are a couple of considerations. Most of them are going to be around traffic flow and actually handling the logistics of moving people in and out of that queue. For the most part, the CVS would be able to handle the inoculations safely, and so I don't think that's a concern. And certainly they have a supply chain of the other adjunct products that will help. Their biggest challenge is going to be the throughput, and especially if we try to ideally have a one-way in, one-way out sort of scenario, they're going to have a challenge there. So they're probably going to have to do some special things to move people quickly, timely through their organization. If they have a large number, they may be taking only walk-ins, as they do now for flu shots, and that could be perfectly appropriate. If we do a mass immunization sort of thing, they might be actually a weak link in that chain.
Very interesting. Because he's my program director, we're going to ask a question from Dr. Stacy here. He asked, Dr. Macis, is it realistic to focus distribution on urban centers in order to build herd immunity? I'm going to ask Dr. Macis. Oh, I'm sorry.
Yeah, I'm sorry. That's a great question. My sense is that it would make sense to start. So the highest return from vaccinating a given number of people is in high density areas where transmission is faster. So a lot will depend on how many doses will be produced, how quickly. We hope that enough doses will become available when a vaccine does get approved, so that scarcity is less of an issue. But if scarcity is an issue, there are guidelines that have been developed by the National Academies of Science, Medicine, and Engineering, and they will likely be followed. But from an efficiency point of view, from an economic point of view, stopping the spread by increasing immunity in high density areas would seem to make sense.
It's very interesting. Dr. Swann, does your research on H1N1 kind of verify that sort of information, that idea of an urban sector?
Well, so let me add a couple of things. When we talk about herd immunity, gaining some level of protection in the population at a national level may not say that there is that level of protection everywhere. New York may have a very different level than Alabama, than California. And the same thing is true for cities as well. So you might have a city. I live in Raleigh right now, and you might have more rural areas. So just because I have herd immunity in one location doesn't mean that that completely stops the transmission and the risk to others. Now, what is possible is that by targeting areas with the greatest risks, you can slow the disease down while you buy yourself some more time to reach the other areas. So in that sense, targeting an urban area while you're getting out to the rural areas can be a good strategy. But if you look at fairness across the population, there might be people who would argue that there's some concerns there, not just about populations of urban and rural, but it might be also across different income levels or across different race ethnicities or across different jobs. So there are lots of considerations that might come into that.
Thank you. My next question is kind of focused on the equity portion of this this disease and getting doses out, specifically to other countries. Been focusing on the U.S. and how we're going to do it in the U.S. here, but I wonder what level of effectiveness is in that last 50 feet of distribution of doing so in places that don't have the same GDP or the same resources to put into paying for doses, especially that Pfizer vaccine that you were discussing, Dr. Swann, about the needing for cold storage and the extreme costs that come with transporting such a program. I think I would like to direct this question first to Dr. Macis, if you would.
I couldn't hear you for the last 10 seconds, Mitch. I'm sorry.
No, that's fine. My question essentially is, will nations that without the same GDP as the US be able to, in an equitable fashion, receive these vaccines at cost, or how does that work?
It is. It's going to be a part of the challenge that we were talking about. There are ethical considerations and economic considerations at play. There are international organizations that are, and wealthy nations have been have pledged substantial amounts of money that have been donated to low-income, middle-income, especially low-income countries, so they can be used to purchase doses of the vaccine. The estimate is that we're going to need like 10 billion doses of a vaccine. The WHO has contributed to this fundraising effort. Other international institutions have pitched in, the European Union as well. There are some, and these are not. So I'm not. So these are ideas that are being discussed. Is it ethical for wealthy countries to receive priority in terms of obtaining the vaccine first? What is special about, is there something special about the fact that the vaccines are being produced in rich countries, and does that give citizens of rich countries, of wealthy countries, the right to be vaccinated first? There's a debate, including in ethics, about whether it is fair, and there are some who do suggest that there is an element of, so it's not necessarily unethical to give priority to citizens of countries where the vaccines have been produced and developed and financed, and it's sort of an extension of the idea that we human beings care first about our immediate family members, members of our community, and so on. And so there is a sense in which, one's own community should take priority, one's own country should take priority. And so if I'm developing a vaccine, then it's not necessarily unethical that there is some priority given to members of my community. Of course, at the same time, there's also, an argument for not valuing lives that are foreign. less than lives of members of our community. There is a tension there, and I think a big part of the answer will be for rich countries to be supportive and devote resources to make sure that people of poor countries also receive a vaccine reasonably soon.
Yes, I would like to build on a question by Raphael and ask Dr. Helton. So on that point, Dr. Helton, Raphael asked about the cost effectiveness of supplying the U.S., but let's extrapolate that to the world of supplying maybe not 100% effective vaccine at cost or above cost. How do we justify doing that?
Well, I think we have to look at what is the cost and the benefit. What are the benefits? If we can build a sufficient herd immunity, certainly the biggest thing that we could see is further expansion of the reopening of our economy. We've had to clamp down a lot of parts of the economy, and so we have a lot of unemployment. We have a lot of extra resources being spent on things like home deliveries, things like that. We can start to repurpose some of those resources in the economy. So I think there are great benefits to moving this effort forward. I see a lot of benefit certainly in our urban areas, not just in the United States, in terms of being able to improve the uptake of immunizations, building the herd immunity. Just because the close proximity of people in those urban areas. I don't know that there's necessarily a right or wrong answer for any given country, but certainly I think we have to look at the benefits overall for the world economy of being able to reopen, being able to get our typical sort of level of commerce reestablished.
Dr. Swann, can you weigh in on the moral cost-benefit analysis from a systems perspective?
So Dr. Helton is right in talking both about not only the cases and deaths that you avert, but also that systemic and societal cost of not being able to open. So all of that is right. And what I would say is, I would add to it and say, I am not anticipating that vaccine is going to solve all of our problems. It may not be 100% effective, of course. We may not get uptake as high as we want. So we are going to have multiple interventions in place. This might be vaccine and face coverings, or it might be vaccine and widespread testing and contact tracing, or it could be all of those. So we cannot get back to some semblance of normal without all of that. And if you just think about the long-term cost of not having children fully in school and the growing disparities between the children who have more resources at home and those who don't, the long-term cost of this is just really significant. So we should be doing everything we can to intervene and get things back closer to normal.
May I just add just a couple of thoughts to precisely that? I think these are really incredibly important points. And I suspect that I don't have any data to back this up, but I do suspect that that some people might be under the impression that the vaccine will mean that we will go back to normal as soon as this vaccine is developed and becomes available. I think we need to make sure that, and if that's the case, that many people will be disappointed. Many people will experience a negative surprise when they realize that that's not the case, that it will take several months, even when the vaccine is approved, it will take several months at least to, again, produce it in sufficient amounts and so on. We will not go back to normal immediately, but if enough people have the false belief of misperception that vaccine means going back to normal immediately, those disappointments might translate into reduced willingness to comply with the rules, and that might lead that might make things more difficult going forward. So that's why it's extremely important that we communicate to the public and that we provide sort of transparent and realistic information and a realistic review of the months ahead, so that people form the right expectations. There are no disappointments. There's a clear understanding of what everyone will be asked to do going forward.
Thank you. I want to bring us back just a little bit. I was thinking about, as the rate of transfer of information is happening with the speed of the news being by the second or the millisecond, if the first round of vaccine distribution to the medical personnel, those in prisons and the like that the CDC has suggested, if that fails, what effect will that have on the long-term take-up of the vaccine? I believe, Dr. Macis, if you could discuss that for a little, that would be great.
I hesitate to even consider the possibility that, that of a failure, because my sense is that the consequences could be dire in terms of loss of trust in the system. We already see, particularly right now in the US, but also in Europe. I'm originally from Italy. The second wave is severe in many European countries. People are taking this to the streets and they're protesting. And of course, in some cases there are, like in my home country, there's organized crime behind some of the protests. But in many cases, it's just regular folks who are protesting, in part, again, because of mistakes in communication. Perhaps, governments should have been more prepared to handle this second wave, strengthening, healthcare systems, strengthening testing, tracing capacity, and they haven't done so. Maybe they didn't expect the second wave to be this severe. And so many people are perceiving this as a failure, and this failure is clashing with what people were expecting, given that the summer was very quiet, or at least relatively quiet in most countries in Europe. The contrast is just too strong, and people are reacting badly. Similarly, I fear that if this first stage of vaccine delivery and that doesn't work smoothly, there could be bad consequences going forward. So we should be planning extremely carefully.
Thank you. Dr. Swann, could you add in, kind of add to that conversation? But I'm also looking to try to understand how this failure might work. So we may be successful at getting the first round out to local, large urban areas, but often failures happen at the extremes, those in rural areas, Montana, Wyoming, those sorts of locations where my family is from. And I wonder about that, trying to get the vaccine to those locations, and if those failures happen and those effects writ large.
So I think it also depends on what you mean by failures. Does failures mean that it's slower than anticipated? Do failures mean that people have to do a lot of calling around to find out where the vaccine is? Or are failures, the vaccine was given, someone was not monitored, and severe health outcomes resulted? Those are different kinds of situations. If the latter one is the most serious of them, because there is so much vaccine hesitancy right now, this issue of trust is really important. Issues around lead time and availability, it will frustrate people. It will lead to reduced uptake, but some of that could be overcome. There are solutions. You could use mobile vans to get out to rural areas. I'm less concerned with the ability to get out to different geographical areas, because we can see that that's an issue. And we have that problem all the time. We have it for our mail systems, we have it for regular healthcare, and it is exacerbated by these differences. But what I worry more about are the ones that are a little bit harder to see, that we don't deal with all of the time. So getting the vaccine out appropriately to Native American populations, where not all of us are facing those populations every day, making sure that uptake is good in the Hispanics and Blacks and whites and Asians across many different race ethnicities, across different income areas, and perhaps more importantly, reaching people with high-risk conditions when the government doesn't have a database of people with high-risk conditions. It doesn't, your census doesn't tell you if someone has diabetes and COPD. You're using other imperfect measures, and not only do you have to reach them, but you also have to overcome the issues associated with potential vaccine hesitancy and meet them where they are and where they need to hear their information, which may not always be from a CDC scientist. They may need someone from their community or their community of faith, or something else. So I'm quite worried about the impact of vaccine hesitancy and the reaching all of these different kinds of populations.
Can I jump in on that? Dr. Swann makes an excellent point. To me, this almost becomes a great case study in population health, in identifying some of the areas where those people are at higher risk, finding out within our community those high-risk individuals, and start to do the proactive outreach that Dr. Swann's talking about. Again, if we're doing what we should be doing around population health anyway, it's a matter of asking the question and leveraging what I hope are the resources we already have at hand to try and make some of those advances now, while we still have time to plan.
And to add to that, it's not only about utilizing the systems in place, but can we use technology companies like Facebook, Google, Apple to try to reach some populations that public health may use more traditional approaches in advertising. But let me tell you, the credit card companies know if somebody is pregnant before anybody else in the household know it. So they surely know who has diabetes, right? I mean, there are lots of different components of our broader system where there may be ways of locating people and reaching them.
If I could also add just a couple of words. So going back to the issue of failure, what it means for this first phase to fail, I would, and going back to the question that I entertained earlier about, vaccinating urban areas first and rural areas versus rural areas, I think what's going to be extremely important to avoid confusion and to ensure compliance is that the guidelines that have been developed and that identify priorities in terms of risk, mainly, that they are made clear and that they're followed in a transparent way, so that there are no misunderstandings about the sequence of priorities and the sequence of events. Forming expectations based on what should happen when, and making sure that everybody has very clear expectations about again, the process is going to make the process legitimate and is going to make it more likely that it does not fail.
Thank you. And before we jump into our final thoughts, I guess I would like to ask one final question from the Q&A. Is there any currently, other than the CDC, a company or a group like a think tank that works solely on trying to frame the question of vaccine effectiveness? Like every year when they try to we try to decide if the flu vaccine is going to be useful this year or is the same as last year. Is there, and this is for anyone, is that system already built, and then how do we build upon it? Okay, so should there be?
So Mitch, are you asking for a think tank around, you said vaccine efficacy? Is that what you said?
So I'm trying to understand if, like, is there, other than the CDC, is there a major governmental or private organization that's goal is to kind of get out the vote, as it were, for vaccines? I assume that there should be.
I'm sure that there's some professional organizations that work on that kind of thing, nonprofits that work on that kind of thing. I do think that you're onto something, that if we treated vaccination campaigns like we treated election campaigns, that we might have some new strategies. I signed up to do some election training recently for social media, where they were training the public to be able to address misinformation and report misinformation to this nonpartisan group that would then go in and make sure that they got the right information there, or if it was a bad actor, that they would report it appropriately to the particular companies in that social media framework. So I do think that there are things that we could learn from that and crowdsource some of the resources.
Thank you. Yes.
You know, Mitch, I think the other thing that we're going to have to consider, and I think there's a question out in the questions box about this. I don't know that we know enough yet about the long-term efficacy of the vaccine to know, are we going to have to get a new inoculation next year like we do for the flu or for pneumonia? I suppose that that's a possibility. And then the next thing that comes from that, we're going to have to make sure that somebody is looking at the idea, if we have to re-inoculate every year, what changes do we need to make in that immunization cocktail, let's say, so that it's going to have the maximum efficacy against what we should consider to be this year's strain, very much like we do with flu shots now. I don't know that we know enough yet, but certainly I think it's a question that's got to be considered.
Definitely. So let's to end this like beyond interesting. I could probably talk to you guys for, I don't know, the next 6-7 hours all about this and probably take an entire course on it. But for the last, let's in like a short sentence, what's something that you think that we need to take away about the supply chain challenge of 2020, 2021 as it relates to COVID-19? And I'll start with you, Dr. Macis.
From my point of view, just the science is extremely important. The human behavioral aspects are at least as important. We should keep them in mind and do not assume that just because we have solved the science, we have solved the problem.
Thank you. Dr. Helton.
Plan ahead. We still have time to figure out how we're going to manage the supply chain of actually putting the needle in the arm. But I think a lot of organizations are playing wait and see, and that could be a problem going down the road. So definitely plan ahead.
Dr. Swann.
I was going to say that behaviors drive everything, and we need to account for that when we're thinking about our systems and designing our systems and running our systems and all of that. So in some ways, it's what both of the other speakers have said today.
Thank you. This has been an extremely interesting topic, and I'd like to thank all three of you for meeting with us today. You can reach these fine folks through email and through their university organizations. And I'd like to thank a special thank you to our entire staff here at CU Denver and my entire HASO team. As you can see, if they come up on the slides there, they have been like rock solid on getting this done and getting this forward. So we we appreciate your time, and thank you so much.
Thank you.
Well, I think we should end, and I hope to talk to you all very, very soon.
Thanks very much.